Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Associates Cardiology. I'm Dr. Seth Bilizarin, a cardiologist with PMA, and I'm with my associate, Dr. Sunny Srivastava, to talk about a topic that is very important if it happens to happen to you, but it's a combination of two things that could only happen to half our audience, and one of them is pregnancy, and the other one is a potential cardiac problem. So Dr. Srivastava is going to review for us, for people who may be interested in this, who are planning on getting pregnant or are pregnant and may have heart issues. What are the issues? What are the issues with regard to going through a pregnancy safely, having a safe delivery, and then the issues that might occur afterwards? So from someone who knows a little bit about this to someone who knows a lot more about it, Dr. Srivastava, teach us what we need to know about heart problems and pregnancy.
Thank you. We spoke about a similar topic maybe 3 years ago. And of note, in the past few months, I've just had a rush of people coming to see me who have nothing serious or major, but heart-related issues during their pregnancies, and it just prompted me to want to revisit this and chat about it a little bit more. And one thing that I think hampers this is that the majority of doctors just instinctively don't put two and two together, heart disease and pregnancy. There's I think a little bit of a bias to assume that young, otherwise healthy women who are conceiving, it's really unlikely that they're going to have heart problems or develop heart problems. And it's true, it's rare. Only about 1% of women seen in obstetric referral centers have any type of cardiac condition. But things are changing. We are increasingly seeing people who were born with congenital heart defects live longer and longer, and to the point where they're conceiving now. So there's a whole new there are a lot of new issues that are surfacing that have to revolve around the care of them. There's also, on the flip side, people are developing heart problems at a younger age, such as coronary artery disease, high blood pressure, congestive heart failure, arrhythmia. And so those issues need to be discussed or addressed during a pregnancy, certainly in the pregnancy. But more importantly, I think a lot of doctors are called to task for not addressing it pre-pregnancy or preconception, that you have a patient with some known congenital heart abnormality, and you haven't really addressed the topic of pregnancy or contraception, or how a pregnancy would go, or what the woman's thoughts are about proceeding with pregnancy. And sometimes we maybe are a little derelict in our duties to discuss those types of things. So that's one criticism doctors get in this field. There's lots of potential issues or problems for women of childbearing age who also have heart disease. There's certain heart conditions, which we'll talk about, where pregnancy could really be problematic or high risk for the mother. And in the eyes of the medical community, pregnancy is contraindicated in those situations. So there's always a discussion about contraception possibly in that setting, or how to handle that type of thing. If one wants to conceive, we need to address what the risk is, either for them or for the baby. Is there any procedure that should be done before pregnancy to correct the defect? That's another thing that comes up. If they become pregnant and are on medications for their heart disease, is it safe to continue those? And it is in some cases, and in some cases it's not. So there's lots of questions that will come up. So one thing to briefly talk about is just a little bit about what happens to the body during pregnancy from a cardiovascular standpoint. There are lots of physiologic changes that take place that are normal, but are important to know about when you're wondering what's going to happen to a certain pre-existing cardiovascular condition. So lots of different hormones are swirling around during pregnancy, and there's alterations in the hormone levels, and it leads to a couple different things. Increased blood volume, which makes sense. Your body's going to need more blood because now you need to supply for two, basically. Increased red blood cell mass, same kind of idea. There is an increase in cardiac output. The heart is going to squeeze more efficiently, and the cardiac output with each beat is going to improve. There is an interesting phenomenon where the body's going to lower blood pressure, and what happens is the arteries out in your extremities, they dilate during pregnancy, and so it can lead to drops in blood pressure in many people, which is normal. But then often, folks can feel lightheaded or dizzy when they get up as a result of this. This is not uncommon during pregnancy. We can see blood pressure running on the low side. So these are all normal physiologic changes during a pregnancy. After delivery, well, let me back up. these changes tend to peak early in the first trimester. That's when they are most pronounced. So that's when someone might have the most dilation of their arteries. They're more prone to swelling of the legs as a result. They may have drops in their blood pressure and be more prone to being lightheaded or dizzy. So it's early in the first trimester. Generally speaking, these changes all revert back to normal by the second week in the postpartum state. Sometimes, though, it may take a little bit longer for that to go back to normal. So, and that's, I think that's a deep enough discussion about the changes during pregnancy. And so then let's talk about, I mentioned or alluded to these high-risk conditions. And there's a set of 4 of them where the consensus opinion is that women should not get pregnant in these conditions. It puts them at very high risk for death. And I think there's a consensus agreement on this. And so the condition that carries the highest risk for maternal death, somewhere between 30 and 50%, is primary pulmonary hypertension. And what that is, it's a condition where the pressures on the right side of the heart and the pulmonary artery are very high and can put some significant stresses on the heart. One other thing that happens during pregnancy, which I didn't mention, is that something called pulmonary vascular resistance, it increases, and so the pressures can go up even higher during pregnancy inside the heart, and that can lead to some severe complications and problems. So if somebody has primary pulmonary hypertension, and as a subset in that, there's something called Eisenmenger syndrome. And it's something that we all learned in medical school, but many people have shunts in their heart, where there's a little hole and blood can flow from one side to the other side, and more often than not, that's okay. Or not more, but often that's okay. But in some situations, the pressures can change in the heart as a result of these shunts to the point where the shunt reverses, and that can be a real problem where it can lead to people having diminished oxygen levels. They can have blue around their lips. We call that cyanosis. And so that's a major problem. So if someone has Eisenmenger syndrome or pulmonary hypertension, that is something, a condition where we, in the medical community, generally recommend it is not safe for someone to be pregnant. Another condition is severe left ventricular outflow tract obstruction. So no one's really going to know what that means, but what I'm referring to is a condition called hypertrophic obstructive cardiomyopathy. It's a condition in the heart where one particular wall of the heart overgrows, and as it grows bigger and bigger, it blocks the blood flow out of the heart as a result of its growth. And when it blocks that blood flow, that's a problem. And when it's severe, it's a problem during pregnancy as well. So that's another condition where the general consensus is recommended that women do not conceive in that setting. If someone has another type of cyanotic heart disease, cyanotic is the word we use for low blood counts where it's leading to blue around the lips or fingertips, blue, low oxygen, that can get worse during pregnancy. And different shunts or holes in the heart lead to this sort of thing. And the other one is something called Marfan syndrome, which in and of itself is not uncommon and is not a contraindication to becoming pregnant. But if you have Marfan syndrome where the aorta is dilated, which can come along with Marfan syndrome sometimes, that is a time where it can be higher risk where you could actually tear the aorta during pregnancy, and that's a medical catastrophe with a high rate of mortality as well. So to summarize the 4 major things where it's recommended that people don't get pregnant, there's the pulmonary hypertension, and then Eisenmenger syndrome that I talked about. There's the left ventricular outflow tract obstruction or hypertrophic cardiomyopathy I talked about. There's other types of cyanotic heart disease, rare congenital heart abnormalities that are beyond the scope of this discussion. And then the Marfan syndrome with the subset or the type that involves the aorta. That's a significant risk as well. And I'm looking down here to just see some statistics. Those with pulmonary hypertension carry a almost 50% rate of death during their pregnancy. So that's obviously very high and quite severe. One other issue to allude to in this is counseling about the inheritability of some conditions as well. So Marfan syndrome, when you talk about genetics, it's an autosomal dominant condition, and so that confers a 50% risk of recurrence in the offspring. There's a wide range of severity of Marfan syndrome and how it's expressed in any individual, and those kind of questions are often discussed with genetic counselors prior to conception. Now, despite all these risks and despite all the recommendations and advice, obviously people are still going to get pregnant, and that's their right, obviously, to still make that choice. But I think it's very important for these types of patients to have very close relationships with their doctors and require a lot of observation and close attention. They often require very early hospitalization as a result. They often require supplemental oxygen. Some of these conditions require blood thinners, and that's complicated during a pregnancy, as we'll talk about later. Labor and delivery might need to be modified. There'll be decisions that need to be made, whether it's a vaginal delivery or a C-section, and there's different benefits to different modalities depending on what the condition is. So those conditions are the high-risk ones. Those four are the ones where we think people do poorly, and it's generally recommended not to proceed with pregnancy. Most other conditions, for the most part, people do well and have good outcomes. So I don't want to paint the picture that this is all doom and gloom, that if you have some sort of cardiovascular condition, pregnancy is not going to go well. And in fact, it's just the opposite. People do very well during pregnancy for the most part. There are lots of different types of congenital heart abnormalities that we alluded to, or that I alluded to. And as we get more advanced with our medical technology, these women are living longer and longer into the years where they're conceiving. And so it needs to be known about and addressed and discussed. And but most of these people with congenital heart abnormalities do perfectly fine. There are those who have non-cyanotic congenital heart defects. That's the key difference. The cyanotic type, the kind with the low oxygen levels and the blue lips, they don't do so well. But the non-cyanotic types generally do very well. There are people who have these holes in the heart that I talked about, and if that shunt, where the blood flow is going in a different direction than it ordinarily should, if it's mild or moderate, those people generally do very well. And in regards to that hypertrophic cardiomyopathy, if people have mild or moderate in their severity with it, they generally do very well too. The next largest group of women to address are women with valvular heart problems, or often we think of it being due to rheumatic heart disease. We don't see a lot of rheumatic heart disease in the West with the advent of antibiotics, but we take care of a lot of immigrants, and a lot of people have rheumatic heart disease, which can affect the valves in the heart. And there can be some nuances to how you handle people with certain types of valvular heart conditions. If somebody has something called mitral stenosis, where the mitral valve is not opening as well, or aortic stenosis, and it's severe, that may require some significant therapies. There are medications that can be safely given during pregnancy that may help alleviate the symptoms. But if it's severe, or if those medications are failing, someone may need either a surgical procedure or a catheter-based procedure to temporarily alleviate the symptoms from the mitral stenosis or the aortic stenosis to get them through the pregnancy. We'll talk later about if somebody's had a valve surgery with a mechanical heart valve in place and they need blood thinners. That is an issue, a complex and complicated issue to get someone through their pregnancy. And interestingly, I think I alluded to this at the beginning, we are seeing more and more young people with coronary artery disease. I'm sure you do too, but we see plenty of people in their 30s now who have had heart attacks and stents, even bypass surgery. And so they present a unique problem in pregnancy that I don't think was much thought of maybe 10, 20, 30 years ago. For example, if a woman needs a stent during her pregnancy, is having a heart attack, it can be done generally during the second trimester and onwards, but with really a close attention paid to minimizing the radiation exposure to the fetus. And of course, it can be done earlier on in the pregnancy too, if it's a life-threatening emergency with a heart attack, for example. But again, a real extra attention needs to be paid to minimizing the radiation exposure to the fetus with lead aprons and such and things like that. So how do we go about assessing one's individual risk with regards to how they will do during a pregnancy? It's not so easy. Obviously, it depends on the type of underlying condition somebody has, but some centers got together and tried to come up with a scoring system to try to figure out who's at high risk, intermediate risk, or low risk for significant maternal complications. And it's not that complicated. Generally speaking, if you have any one of those complex conditions I talked about at the beginning, those 4 conditions, it puts you in a category that's high risk. But there was a scoring system. They actually added something else in there. You get a point if you had had a prior stroke or heart attack or complicated arrhythmia. You get a point if you had one of these cyanotic heart diseases. You'd get a point if you had severe hypertrophic cardiomyopathy, or you get a point if you had severe congestive heart failure or a weak heart muscle. And you get a point for each of these, and women with 0 points, or obviously, it should make sense, were considered lower risk. Women with higher points were considered high risk. Those with 3 points had, what was it? It was a 75% risk of having a cardiac event, which is quite high, obviously, and one would be counseled not to proceed with a pregnancy during that, with that type of score. So I've talked about a few things here, but what is the actual most common cardiovascular thing that we encounter during pregnancy? And that's actually high blood pressure. You probably see that not infrequently in your office setting. I see it certainly not infrequently in my office setting. It's the most common cardiac, if you will, if you want to call it that, most common cardiac complication in pregnancy. Certainly if you have a baseline history of high blood pressure, it's not surprising that you will have ongoing issues with high blood pressure during the pregnancy. And we consider, there's a way we evaluate this. Lower risk individuals have their blood pressure, that top number between 140, 160. It's certainly easier to manage. But if somebody has a blood pressure that's higher than that, with that top number, or if they have evidence of EKG abnormalities or structural heart abnormalities or kidney problems as a result of the high blood pressure, it makes it a little more complicated. And we're a little more aggressive with the therapies for it. And certainly significant medical problems can ensue if it's left untreated. Blood pressure pills, there's certain ones that are more favored during pregnancy than others, but certainly antihypertensive or anti-blood blood pressure pills should be continued during pregnancy. And in some instances, as I mentioned early on, blood pressure can drop during pregnancy. And so that may happen, and actually I've seen people who end up during pregnancy not needing their blood pressure pills and then later having to go back to it. There's one particular drug that I think the obstetricians have used over the years more than any. It's called methyl-dopa. It's not one that we generally use in the usual hypertensive population, but it has a very safe track record in pregnancy, and so that's often considered the first choice during pregnancy. One downside is that it's often has to be taken 3 or 4 times a day, so that's a little bit of a nuisance for some people. There's another class of medication called beta blockers that people take for a lot of conditions. Those can be safely administered during pregnancy with the exception of 1 or 2 of them that might not be, but by and large, beta blockers are fine during pregnancy. There's another condition that's more ominous called preeclampsia, and that's blood pressure, but then your kidney starts to spill out protein in the urine, and that needs to be treated. The blood pressure needs to be treated, and what can happen is if that's left untreated, it can progress to eclampsia, where mothers can have life-threatening problems with seizures and other issues, and so we by all means want to avoid letting something go and form into eclampsia. That's a high-risk situation. There's another thing just called gestational hypertension. This is a situation where just during the pregnancy, for hormonal reasons and changes, the mother develops high blood pressure, but then after delivery and reverting back to her normal state, it goes away, and it's not an issue. You can think of it, sometimes people develop what's called gestational diabetes, and so the same idea. It's there during pregnancy, but once things revert back to normal, it goes away. So that's the issues, I think, with high blood pressure. So I mentioned methyl-dopa as the main drug of choice for that. There's a couple others. We'll get to the drugs in a moment. There's a few other things I want to hit on before I talk about the drugs. I mentioned early on something called Marfan syndrome, where it can put somebody at risk for aortic dissection. Or if someone's had previous aortic surgery where, as a kid, they had something called the coarctation of the aorta. If they had that repaired, they may be more prone to dissection. And what dissection is a tearing of the aorta wall, basically, and that can be a medical emergency. Some cases, depending on where it is, it may require emergent surgery. In other cases, depending on where it is, it may just be a simple medical therapy with treating the blood pressure. And one thing that I think we all need to be aware of, but I think you and I have probably each seen a few people with this in the past few years, is something called a peripartum cardiomyopathy. Cardiomyopathy is the word for a weak heart muscle. We've talked about it numerous times on this show in other settings, but this is a mysterious one that rarely, and actually it's about 1 in 15,000 pregnancies in America will lead to this, although in other parts of the world, on the opposite, in Haiti, 1 in 350 pregnancies will lead to peripartum cardiomyopathy, which is a staggering number. But generally speaking, in the immediate postpartum period, within a few days, these women can develop fulminant and severe congestive heart failure. And when you do an ultrasound of their heart, you can see a weakened heart muscle as a result. and they can be critically ill, and you have to treat them like you would any other patient with advanced congestive heart failure. There's lots of medicines that are used. Sometimes they require mechanical devices to support them and get them through that. And often people do well with this, and they get their heart function back, and they do okay. Not always, but often they do. And one key point is that these women are at high risk for redeveloping the problem if they conceive and deliver again. And there's a study actually showing that if the heart strength is lower than 50% in something called ejection fraction, they have a 44% likelihood of redeveloping this again. If their heart function is greater than 50% or normal, less than 20% would redevelop this. So that's one way to guide people through this. But generally speaking, these are high-risk patients that we tend to discourage from another pregnancy if possible. And again, it's always someone's choice, and our job is to give them all the information, and people can make educated decisions based on the information. So I know we're up against the clock here and starting to run out of time, so real quickly, I just wanted to mention about medications. People always ask, what can we take, what can we not take? And so real quickly, just to run through common cardiac drugs during pregnancy. If someone has arrhythmia and are taking a medication called digoxin, that's fine during pregnancy, not a problem. Methyldopa for blood pressure, we talked about. Diuretics, it's some controversy. If it's absolutely necessary, it can be used. There's some theories out there and some studies to suggest that it may trigger preeclampsia, so there's cautious or judicious use of diuretics. ACE inhibitors, a type of blood pressure medicine, absolutely contraindicated in pregnancy. Beta blockers, relatively safe. Calcium channel blockers, plus minus. Amiodarone, another antiarrhythmic drug to try to avoid. And that's sort of and then blood thinners we didn't even talk about, but I think we are truly running out of time, but blood thinners during pregnancy are complicated. I'll leave it at that. Wow, and you did that all in one breath, too, which I thought was especially amazing. So Dr. Srivastava has done a fantastic job today reviewing for us some women who are high risk. He gave us 4 disease entities that are high risk for pregnancy. He gave us some of the issues that occur during and after pregnancy, and I think gave most importantly the message that, early follow-up, early identification of pregnancy, and then identification of other health issues with first, of course, the obstetrician, and then referral to a cardiologist if appropriate. Something that you have an expertise in is a strategy for optimal outcomes after pregnancy. So thank you for this great review of the issues of pregnancy and cardiac conditions. And I thank Dr. Srivastava for joining me today here on Haverhill Community Television's Matter of the Heart. Thanks and good night.